You started out as a cancer surgeon before moving into health systems, policies, and global oncology. The first question I want to ask is what informed that shift?
Yeah, wonderful question, Paul. I guess slightly fortuitous. I was very sort of classically trained in medicine at St Mary's and then went on to do surgical training and then, a really quite reductive PhD in biochemistry at UCL. But at that point, I kind of slightly jumped ship and went to the pharmaceutical industry to Merck Darmstadt to work in heading up their R&D section. And I was recruited out of there only after a couple of years by a very famous, late and very eminent medical oncologist called Professor Gordon McMee into the Cancer Research Campaign, which became eventually Cancer Research UK. And it was really within Cancer Research UK, because of the work I was doing as clinical director, that I started to see the kind of wider picture of not just the reductive aspect of technologies, but how health systems and services are such a significant influencer of how population outcomes are generated. And this encompassed everything from the welfare state and social determinants, the Michael Marmot area, all the way through to the organisation, structure, governance, financing. And we were very lucky because Cancer Research UK was, in those days, a very forward-thinking organisation and also quite a global organisation. And because of my background, I was born in what was AID and the British Protective Agent, spent many years in East Africa, living there as well. Because of my background, I had much more of a tropism for looking at this from a sort of global background. And really, that's really what caused the shift. Is I realised that a lot of our outcomes weren't determined by the technologies that we have, the drugs, the radiotherapy, the surgical robots, but rather by the services and the systems and the construction of those, and policy, of course.
What experience do you think has shaped the way that you think about cancer control today?
Yeah, I think we're in a tension. And that tension in the moment, and it's not just within high income systems, I'm seeing this all over the world, is that there's a tension, I think, between technological innovation that's going on within cancer control. So these are new drugs, radiotherapy, surgical, and it's been dramatic, the improvements in new technologies. So I want to recognize that for a moment. We have better surgical approaches, better radiotherapy, and better drugs than we've ever had. I mean, in England and Wales, you can see we've had a doubling of survival overall in cancer since the 1970s. But at the same time, of course, this produces enormous stresses and strains on health systems to ensure sustainable and affordable futures, to ensure that these technologies actually change outcomes, number one. And for many countries which don't have, a social insurance or a socialized system, of course, all of these technological improvements, of course, come at a cost. And these costs can be directly on families and patients. And in many cases, they're utterly catastrophic in most parts of the world. And then on top of that, of course, what we're seeing as well is a divergence between those that have and those that don't have. And it's not just a simple matter of high-income countries versus middle versus low. Even within middle and low-income countries, there are groups of individuals that have access to very good cancer care, either because they can afford and pay for it in major urban centres, or they can leave their country and go abroad to get treatment. But this inequity is growing. And so I think when we're looking at this, these are multifaceted challenges looking to the future. But I think this issue of inequalities and also affordabilities are probably the two key issues, I think, within the policy domain looking over the next sort of 10 to 20 years.
I know you've worked in various contexts from the NHS to fragile and conflicted areas. And of course, you've also worked on several global commissions. Connect those uniquely different experiences for you. So what is the thread that you think connects everything for you?
I think there's a kind of mental model of cancer and systems as complex adaptive models. I think always in my head, it's how all these aspects interconnect. When we're doing pieces of foundation and fundamental thinking like the Lancet and the Lancet Oncology Commissions, what we're doing there is kind of integrating some of the sort of, the key thinking that is current out there and the key evidence. On the other extreme, of course, there is a kind of adaptive reality. A lot of the papers I think that we do, a lot of commissions that come out can feel a long, long way from the reality of patient experiences and delivering care in different settings. And I kind of think of this kind of, there is a lot of people talk about resource stratified care. Well, actually, a lot of this is about reality stratified care. you can only do what you can with the patients who come in front of you and with the technologies you've got in your hands. And I think what sort of pulls these two threads together for me is how do you integrate that kind of high level academic evidence with the lived reality in these countries and create a kind of policy and political economy environment that can actually transform change, that can actually push that. Because I think there's an awful lot of work that we do which is very, very disconnected from the need to actually change and improve the lives of patients on the ground. And there's one sort of final aspect as well is of course, by getting people to think and to challenge the prevailing orthodoxy, what you're getting then is setting people up for the future, if you like, because by challenging the standard orthodoxies, particularly when people say, oh, everything's absolutely fine, and you point out things are not fine, once you admit there's a problem and there's missing pieces, at least then you can have a dialogue for change and you can focus on those pieces of change. So I think those are things that connect these together. But it is, as I say, quite a nebulous thing that you have to hold in your head.
It's a lot. Speaking of the interventions itself, I know these new reports, when I was reading it yesterday, one of its key suggestions is that $3 per person per year could save 12 million lives and unlock $1 trillion in benefits by 2030. And this is not the first time we are getting some of these projections around how economically beneficial investment in health. But from your perspective, do you think that this brings any new dimension to the conversations around how we control cancer globally?
A positive thing is investing in health improves your economy as a whole. It improves the future for children and education. It generally drives development. And we, by the way, we've known this for 40 years. There's nothing new at all about this. We know investing in cancer plans in a sustainable manner also produces substantial returns on investment. Again, Lancet Oncology for the last decade have producing reports on everything under the sun. Investment case for radiotherapy, investment case for general funding. You've mentioned WHO, the World Health Organization, Best Buys. We've known this, and we've known this for a long time. And that's fine. At the highest level, that's fine. But there is a disconnection between that and then the individual realities of countries and then the realities of the lived experiences within those countries. And I think that is where the problem lies. And the reality factor here then is that in order to deliver affordable care in countries, you have to have realistic cancer control plans that are financed. And that requires adaptive health technology, health benefit packages, social insurance model, free at point of care. It doesn't matter how you do this. And the problem is developing these things requires extraordinarily strong political governance. It requires real expertise in developing the right sort of plan and, more importantly, implementing that plan with the right sort of financing. And the right sort of financing, by this I mean sustainable financing. And it requires you to say no to certain things and yes to other things. And the ability to see the wheat from the chaff when it comes to deciding on what core services. And then, as I keep saying to people again and again, cancer does not operate in a vacuum. Cancer reflects all the strengths and weaknesses of our health systems. You can't have a fantastic national cancer control plan if your general health plan and labour force plan and pathology plans are all weak or non-existent. And then, of course, and the final point to make is countries are at a very different stage of development. It drives me utterly crazy in global cancer when we talk about low and middle income countries. It's meaningless. You're putting Chad and China into the same group. Okay? It means absolutely nothing. And it's not even meaningful for the demographic leviathans like India, Brazil, and Nigeria. You take India, the standard of care and the outcomes you see in Kerala or Tamil Nadu are light years better from what you see in Uttar Pradesh or Bihar. Okay, so there's an entire world in one country. So there's this, you have to focus on countries, number one. You have to focus on the reality of that country in terms of their development space. And that reality then, as you say, dictates what they're actually able to deliver in the short and the medium term. You cannot expect low, fragile, conflict-impacted countries to develop the sort of national cancer control plans that Turkey or China have. And you see that in the data we've got. You see these massive differences in survival, and of course, and then that's what it reflects. So I think, I think it's all very well. We keep seeing these cases for investment and the support, but the reality is all of this really rests at national level, and that's where you've really got to focus your policy and your political efforts.
Yes, thank you very much. Taking that further, I want your thought on why you think cost effectiveness arguments haven't yet to stronger global actions.
When you do a cost effectiveness analysis, it has to be part of a prioritization exercise. That's what health technology assessment programs are. And there's something now we call adaptive HTA processes, which provide different levels of evidential prioritization based on how much time you've got and how much detail you've got to do this. And you've got to remember, it is a locally time-dependent decision. You have to just, it's dependent on the wealth of your society, the GDP, GNI. It's on your willingness to pay threshold, how much you're willing to pay per quality adjusted life year. And each of those decisions is utterly unique for an individual country. Even when we talk about health benefit packages for breast cancer or colorectal cancer, there are multiple different health benefit packages depending on how sophisticated it is. As I try to explain to people, in colorectal cancer, there are very relatively cheap anterior AP resections for bowel cancer, going all the way through to really quite expensive and complex procedures like total mesorectal excision. Okay, that's all in colorectal. The same with breast cancer. Doing a straightforward mastectomy is 1,000,000 miles away from doing oncoplastic reconstruction, which again is a more expensive package. So it's got to be unique to the country. You've got to be very specific about what health benefit package is. And thirdly, the big issue at the moment is we don't have cost of illness data for cancer in many of the resource-constrained settings we're talking about. Most of this data is extrapolated and generalized from high-income countries, and that's no good either. And so we need a lot more health economics for cancer in the settings where it's...
I know you mentioned some of the cancer best buys, and of course they include HPV vaccination, cervical and breast screening, early childhood cancer care too. Which of these do you think is most realistic for countries to scale up, especially within the next 5 years?
Yeah. So we're coming close to finishing a major report for the World Bank where we've looked at this in great detail. And I'm going to say, actually in that sense, we kind of concur with something. We're producing the evidence to show that from a site-specific cancer perspective, colorectal, cervix and breast are the three fundamental ones to focus on. Now that is a truism regardless of what income level you're at. And the reason is because they're all, number one, they all require surgery. And that, of course, obviously you have to have basic surgical training before you do oncological surgery. They all require in different forms radiotherapy, which is one of the key modalities. And of course, it's one of the key modalities which is completely cancer specific. And to a lesser extent, they also require reasonable essential cancer medicines within specific regimens. And I'm talking about the advanced cancer medicines here. So those three, if a country focuses on those three site-specific cancers for its services and systems, it will go a long way to reducing premature mortality due to cancer. I completely concur as well with the hepatitis B and HPV. I think there's a lot of complexity around HPV. We're seeing great progress in some countries. Other countries are stalling. Others are going backwards. That's sort of a separate issue, but there's a lot of heat and light. Hepatitis B is a big thing, though. And I think that's been a much more complex issue. We've seen how some countries have engaged in this, but I guess all of these require long-term, consistent commitment. And I guess the only way that we're going to see this in the new environment we're in is either through domestic resource mobilization and or funding from multilateral development banks. And that includes big new players like China, for example, coming in, who are turning out to be extremely important for building cancer capacity in sub-Saharan Africa, Latin America. And I think, that will be a massive help over the next 10 years as well.
Yes, thank you. One of the things I've seen is screening and early diagnosis is really at the crux of reducing the cost of cancer care and cancer management, especially if we are able to target some of the preventable cancers. This could serve as very affordable interventions. So what lessons from countries that have scaled early diagnosis and screening up, that have been able to achieve this successfully, that you think other countries should be paying attention to?
I want to frame it slightly differently. What matters is end-to-end care. So I constantly say to people, the two lethal vectors in cancer are time and the quality of your care. And they are equally important. Time to diagnosis, time to getting your treatment, and then the quality of your treatment. Without those all aligned, your outcomes would be lousy. You can get early diagnosis, but if there's no treatment there or the treatment's substandard quality, your outcomes will still be lousy. And that is one of the problems when you think about cancer pathways. And I'm going to be blunt, screening is a relatively minor component of the early diagnosis. It's not really even early diagnosis. Even in high-income countries with all the screening programs, less than 5% of our patients are diagnosed through screening pathways. What matters is the ability to diagnose cancer at an early stage in a general health system. So, and that, of course, for individual site-specific cancers, that is determined by different forms of modality, symptom recognition, etc. Diagnostic modality, symptom recognition. So putting all of this together is for many countries, I think, the absolutely key thing. It isn't just a matter of saying, I tell you what, let's just put an early diagnosis or a breast cancer screening program in. And I can show you chapter and verse. This is why things have gone wrong in many countries. They've just put money into screening and early diagnosis of breast cancer. There's no downstream treatment, or the treatments are unaffordable. And guess what? You don't get improvements in outcomes. So when you look at countries, and I'm going to use an example of something like Turkey with universal health coverage, that have seen really dramatic improvements in outcomes, it's because they've done this end-to-end approach. They've gone for the time problem. They've gone for the quality of care problem. And I keep saying to people, that is a massive, massive issue in many systems, in both public and private. And what they've done is dealt with those as a whole for individual site-specific cancers. And I think, that is the way forward. And I think we need to shift away from this thinking of screening, early diagnosis, access to treatment, access to chemotherapy. It's not going to improve outcomes as a whole. And I think it's also going to cause a lot of policymakers and governments to simply just go the wrong way in terms of their investments.
Yeah, the burdens of non-communicable diseases, the burdens are so massive, but only 1% of global health goes to NCDs. So how do you explain this mismatch?
It's true. DAH, only 1%. It is meaningless money. I think the general problem is, cancer, and I want to separate out cancer from other NCDs. That's another thing is one of my big bugbears. I've no problem talking about NCD risk factors, because you're absolutely right. Lots of risk factors for cancer are also the same for a cardiovascular system, etc. So it makes a lot of sense with prevention and public health. But when it comes to care, service and systems, cancer is not diabetes, it's not hypertension, etc. A lot of the NCDs can be managed in a primary care setting. Cancer is a hospital-based service and systems approach, and that puts it in a completely different league from the other diseases within the NCD group. And I think, when we're looking at the investment that's gone in, I think in high-income countries, as we've seen, enormous amounts of money have gone in to cancer. And indeed, cancer is now one of the engines of the biopharmaceutical industry and, commercial returns, etc. I think in other countries, what we've seen, though, is that they've struggled to catch up. And the reason is that their transitions have been so much faster than ours. People forget we had nearly 100 years to go through the epidemiological and demographic transition in high income countries. When you look at, let's say, the middle income country groups, the aging population and the demographic expansion are enormous. And then the risk factor. So and not only has the speed of the aging population, which is obviously related to cancer, increased dramatically compared to high-income countries, the amount of risk factor exposure has increased, and thirdly, many are having to deal with double burden. So not only are they dealing with NCDs, they're still dealing with infectious disease issues, child and maternal mortality, and so the complexity of development and disease in many countries is really quite sophisticated. And cancer, to get good outcomes, does require very, very robust political governance. You look at the Chinas, you look at the Turkeys, Costa Rica, it's because government in sub-Saharan Africa, Rwanda's a good case study, Namibia as well. You've got to be quite ruthless in terms of managing the infrastructure development, in terms of ensuring the quality of care, developing the pathways, etc. If you just allow the system to develop ad hoc in private and public, you won't get good outcomes. But I think, looking back at this, I think with the DAH issue, because I think ODA has been so focused on infectious disease, child and maternal mortality, and continues to be, there's just no place within the thinking for non-communicable diseases. And I think particularly oncology, I'll say this very overtly, and this will probably upset quite a lot of people. I think there's willful ignorance in most of the global health community about cancer. I'm shocked by how little they understand. And I think partly that's, let's say, willful ignorance on one side. It's also been our problem from the cancer community explaining why cancer is a development problem. and clarifying the complexity of cancer.
Yeah, a lot of reports, not just this one, several other reports continue to emphasize fiscal measures such as alcohol taxation, sugar tax, taxing tobacco. And so how would you describe the power of these tools to be able to serve prevention and also to finance cancer services? So what insights can you share on these tools?
So I think what I'm setting out too, taxation works. We've seen it in tobacco. You tax tobacco products, it reduces their usage. They are politically difficult things to do in many countries for all sorts of reasons, because national tobacco industries provide revenue into politicians' pockets, or because the companies themselves actually fund political parties. And I think you have to look at the difficulty still with tobacco to then appreciate when you get into food and beverages, and particularly alcohol, how even harder that area is. And I think this is about sort of broader geopolitical and political economy issues here. And I think, when we look around at what's going on with public health and prevention measures generally, you see some countries have actually grasped the nettle and are doing well. A lot of others are not. And I think there's a sense that no matter what you do, even with all the prevention and public health measures in place, in the next 20 to 30 years, as populations age, you are going to see higher and higher burdens of cancer. And I think that still remains a major challenge. Even if you can reduce some of that burden, which is what you should be doing, you're still going to have a significant burden. It would be, I genuinely, that's why I'm, such a big advocate of the HPV vaccination, because if we can just address one of them through prevention, that would be fantastic. And I would argue with hepatitis B as well, in reducing hepatocellular carcinoma impact in many countries. But the reality is, in the majority of countries, we are going to need more and more care to be put in place, because the burden is just going to grow because of the aging populations.
So the health burden is increasing while finance is shrinking. So how would you describe the future of funding cancer and NCD responses? Do you think they will mainly be domestic resources, or do you still think there is still space for new global funds or platforms like the Health for Fund to make a significant difference?
I think a lot of this is going to be domestic resource mobilisation. I think then that immediately puts enormous stress on a whole range of countries at the moment that are now having to take from their NCD budgets to backfill what's been lost from other areas. There is a sense as well, when you look at the data on government health expenditure and current health expenditure generally, that unless a lot of these countries start improving the basic financing of their health systems, we are still going to be where we are today with cancer control. Because as I said before, cancer control only works on a solid foundation. I'm extremely concerned about the data on out-of-pocket expenditure. Universal health coverage is not a popular subject anymore to be talking about in the UN system, progressive universalism, because guess what? It is to all extent and failed. Again, within cancer, huge numbers of people experience catastrophic expenditure for a cancer diagnosis. And I think when you look at countries that are going to get on top of this, it's because they are putting a basic amount, around 5% of their GDP into their health system. And on top of that, then they are being ruthless about what they're going to fund within their national cancer control plan. And they're really being extraordinarily clear about social insurance, the health benefit packages they're going to put together, and they're going to have a long-term plan for building the right sort of infrastructure. And if that is the case, then I can see, multilateral development planks, I think, playing an increasingly important part. And I hope the sort of World Bank report we're doing will spur not just the World Bank Group, but also other MDBs and major countries like China to think and consider much more carefully about how they fund national cancer control plans in individual countries. Because as I said before, the idea of LMIC, global cancer, is meaningless. It is country by country and region by region. And I think there's some promising green shoots in that. I think people are starting to think about how to do this properly now. And I think certainly from an MDB perspective, that will provide the rigor that's required in order to make sure these plans actually move forward, rather than just a bit of ad hoc technical input now and then. But I think it's going to be a hard journey over the next 10 years.
I also want your thoughts on equitable implementation of cancer-based buys. One of the interesting data in the report was that 8 out of 10 premature NCD deaths occur in LMIC countries. So what are thoughts around equitable implementation of cancer-based buys to ensure that rural and vulnerable communities are reached?
It's a massive challenge. I think when we talk about hard to reach communities and rural communities, the distances, geographic barriers, cultural barriers, etc., are really, really significant. I spend a lot of time working with my friends and colleagues in Zambia. And, if you're lucky enough to be of a certain wealth bracket and living in Lusaka, there's some very good care. If you come from the Copper Belt up in Ndola region, etc., or in the south where Livingston is, care is a long, long way away. And I think when you're talking about this, these are not easy, straightforward things to do. It's not a matter of just building a hospital services in. The outreach into the community that's required, the development of the pathways. And we see this in countries which have got more mature development, like India, for example, about the time and efforts required to outreach into complex rural communities in order to get a timely diagnosis, to get them there presenting on time, number one, and then for them to stay for their treatment and not abandon, even if the treatment is free. Because again, when you're talking about these populations, you will often see these are populations, daily wage earners, etc. A lot of our pathways, again, are too long. They take too much time. And it's fine if you live in a nice high-income country where you've got social support for you to go backwards and forwards to the hospital over 3 or 4 months. But if you come from a rural village in the middle of Uttar Pradesh and you're being required to go backwards and forwards to a hospital hundreds or maybe 1,000 kilometers away, that's going to be economically ruinous for you. You're going to abandon treatment. Or if you have a child that needs this treatment constantly, you're going to take that child out of treatment because you simply can't afford it. So I think, this requires, again, specificity of implementing a national plan at a local level and at a regional level, depending on the size and complexity of the individual country. There are no generic solutions to any of this. Every country is unique in its cancer trajectory.
I think you're also answering the next question, which I think indirectly leverages your experience in researching cancer, controlling conflicts and fragile settings. All these global recommendations that we are getting, how do you think they can be adapted for countries dealing with instability and humanitarian crisis?
Yeah, that's an excellent question. Last year, we obviously had the first declaration from the World Health Organization, co-signed by Dr. Tedros, on the importance of cancer in crisis and conflict. And that was followed up by a meeting in Copenhagen where we developed an operational plan, which was kind of an operational viewpoint, I would put it that way, that was published in the Lancet Oncology. I think first to say is conflict and crises systems around the world are very different, but they are growing. We're talking estimates about 2.5 billion human beings now, but the impact of let's say a natural disaster like a hurricane in the Caribbean is 1 million miles away from what's going on in the Sudan. And even within conflict ecosystems, what's happening within Gaza and Sudan and places like that, these are very, very different. The cancer care, I'm about to go to Lviv in Ukraine to talk about cancer care in Ukraine. Actually, that's still very sophisticated. But again, the adaptation of cancer pathway, the adaptation of cancer guidelines to conflicts are going to have incredible specificity depending on the actors in that conflict, number one. And number two is what we realistically deliver. And I think we're yet to really dissect all of this out. So I think there's a whole lot of work to be done in understanding what reality-stratified care looks like for NGOs like MSF and ICRC in conflicts, cancer care for refugees, how to support host countries, because most refugees are hosted by other middle-income countries. And then there's a whole issue really around, to be blunt with you, international humanitarian law anyway, which, is a separate issue there. And then also, I think the pandemic, COVID-19, illuminated also within many countries the fragility of our cancer systems to future pandemics. And I don't think we've really learned how to build in any form of resilience into our systems. We've got a lot of lessons learned in terms of, adapting surgery, regimens of chemotherapy, what you can and can't do with radiotherapy. But those haven't been really taken and then adapted and integrated into any form of national cancer control programming, which needs to be done. And it's something we've been talking around for quite a while now. Myself and my good friend Gevorg from Armenia, who runs the Institute for Crisis and Conflict, it's something both of us feel very passionate about, and it's something I think from a future perspective is how to build in resilience for conflict and crisis into countries is something that we really need to focus on and do much more work on.
In the report and several others, the UK continues to be cited as a success story, from HPV vaccination to sugar level and organized screening. From your perspective, what do you think the UK has done well, especially in the area of cancer prevention and control?
Yeah. I think the prevention agenda, I think tobacco, we've done very well. I think over the years we've really learned, and we've been very lucky because, of course, we've had some of the world experts like Sir Richard Sullivan and others who've really driven the evidence for this. I think on the public health element, we've done well in certain areas. You just mentioned HPV vaccination. We've done less well on the social determinants, whilst things were getting better once upon a time. If you look at the Malcolm Marmot report now, things have actually deteriorated. But I think overall, since the 1970s, survival has doubled. If you look at individual site-specific cancers now, survival in breast, etc., is the best in the world. Okay, which is a remarkable. We still have cancers which do very, very poorly and have glacial progress, pancreatic cancers, but that's a truism all over the world. And then we've got this kind of middle group of cancers where some we've done well at, and things like urological cancers we're not doing so well at. And we're far less than you would see in terms of outcomes from places like the Nordic countries and Denmark. And I think there's a tendency in England for us to give ourselves a really hard time about not doing as well as X. People forget, I think, England and Wales, Scotland, Northern Ireland, it's a complicated multicultural country now. We've got lots of barriers and factors around, urbanisation, access to travel, complexities of the way we structure our care and organise our care, barriers with, rural or hard to reach communities and coastal regions. And there are, and that kind of this whole protean complexity creates a lot of friction in the system. But as I keep pointing to people, but, when you get a cancer diagnosis, still broadly, you will get very, very good care. And the majority of people do extremely well. And by the way, when you've finished your treatment, you won't be bankrupt and your family won't be bankrupt. And people kind of forget that, there's this, we're very, very lucky to have a national health service. And that's not to say there's lots of problems. There are lots of problems that need addressing. But I guess the ethos of having a national health system which looks after people and what we've managed to deliver in what has been quite a constrained budget, our budget in the healthcare system has been flatlined for 14 years, is really, really quite remarkable. And that's not to say there's lots of things we can learn from other countries. There is. And there's a lot of things that we have to get our own house in order. And I think right now, the political economy of cancer in the UK, workforce, the services system stuff, it isn't working. There's a great deal of dissatisfaction within the clinical community and patient community about things that are not working properly that should be. But I think overall, we've done actually remarkably well. But I think we need to have a reset now and really focus on care that matters and technologies that really deliver outcomes and models of care that really deliver outcomes. And we've got to find a way of not wasting precious resources and patient time.
Yeah. I think you also answered the second part of my question, because the UK is also facing rising obesity, and you also mentioned persistent health inequalities, especially in some of the hard-to-reach regions that you mentioned in the coastal areas. And of course, nobody can forget the increasing pressure on the NHS. And in addition to the several others that you've mentioned, looking at where the country is at the moment, so what would you describe as the biggest gaps in the UK's cancer response? First
and foremost, social determinants of health. It's so important, and it's not just important for the fact of how a healthy population is less likely to develop cancer or develop it when they're much older, so they have more years of healthy life. It's also the fact that, we're seeing more of our patients now with other comorbidities, and that is a significant issue when it comes to cancer care. It makes it more expensive, makes it more complex, and also the lived lives of our patients, what kind of environment they go back to. A flat on the 16th floor where the lift hasn't worked in an estate for the last 15 years and they're short of breath. So there's a whole issue around the social determinants, which is still absolutely critical for our overall cancer outcomes and cancer system. And then, I guess, looking at things overall, the first thing is the workforce. Again, I'm not saying it's easy, but it is much, much easier just buying and putting in new radiotherapy machines, buying new surgical robots. That's the easy bit. The hard bit is the human beings who are going to do the caring. And none of the technologies we use in cancer reduce the number of people we need to care for people. So, deficits in clinical oncology, medical oncology, our surgical workforce are, super critical. And they take many, many years. And then those teams have to work in a functional manner, which requires governance. And there's a sense at the moment that, the governance of clinical teams, things are not quite working well enough from the old days of the firm, and that something needs to be done there. Physical infrastructure will come to, because we have massive deficits in operating theatres still in the UK. We do have deficits in the latest radiotherapy equipment. We don't, in my view, have deficits in systemic therapies. Actually, that's one area where we've got plenty of those. But the ability then to deliver these in a coherent, end-to-end manner is going to be essential. And I think we're still struggling with this problem that NHS trusts within cancer care are not integrated together. We have something in the England called the National Cancer Audits. They're amazing. It's the best cancer intelligence data in the world on quality and shows huge quality differences between hospitals. So these are negative outliers and positive outliers. In other words, hospitals for their volumes doing incredibly well. And these are all sorts of quality indicators. It's not just simply outcomes, it's sort of functional disability things in between. We have a lot to learn from those audits in terms of improving quality of the care. And again, I keep saying, stop investing in new technology and put more money into the basic structural elements of improving quality, of paying your staff better, of having more staff in the system, and generally looking at the end-to-end governance. And again, people are interested. We've written with sort of, clinical experts ad nauseum now in the Lancet Oncology, all sorts of pieces. And I think for England, Wales anyway, we'll wait to see what the National Cancer Plan, when I think comes out probably very soon, says.
Yes, I think we cannot ignore the rising, probably loud increase in this nationalism in the UK. But I am capturing this question differently, because the UK is also very, very active on the global scene. So how do you think the UK should balance its domestic cancer challenges with contributing expertise and resources to global cancer control?
I've been disappointed with what the UK has done on the global scene. In fact, I would go further. I've been very disappointed. I think from a government perspective, federal funding, and from a charitable perspective, we should be doing a lot more. And it's not just a moral duty point here. It's the fact that we live in a massive multicultural society. We have huge links with other countries. And if you really want to be instrumental about this, actually, it's a very good area for soft power as well. I mean, people talk about, global health superpower. Well, cancer is a phenomenal place to put money into capacity building, research, education and training. But what we've seen, unfortunately, though, is a complete retreat from that. If you look at what's going on now, the Medical Research Council applied, global health board's being closed, National Institute for Health Research is closing down a lot of its global health funding, including cancer. We're just not seeing, either from a government perspective or a charitable perspective like Cancer Research UK, others, people showing a broader vision to the rest of the world. And there's not to say there isn't bits and pieces of money going in, there is. But generally speaking, for the wealth and the amount of money we're putting in, it's pretty poor. And by the way, it's not just from a national perspective. I would point the finger as well at the pharmaceutical industry and the medtech industry. They put peanuts compared to what the profits they make. The amount of money they're putting into countries to help support cancer planning is peanuts. And often it's in the wrong areas. So it's kind of, when you kind of stand back, you think, wow, considering how much money is in cancer, in research, in cancer control, considering how much wealth cancer technologies generates for companies, for individual universities, etc., what we're actually spending on the global scene is pretty appalling. It's pretty appalling. And again, we've tried to make the case again and again for this, but cancer is not part of the global health research or global health agenda per se. It is an orphan area. Again, it's dominated by the infectious diseases, child and reproductive mortality. And I think that's a shame, and that needs to change. Because again, looking at sustainable development over the next few years, there are lots of really important research questions that, researchers in the UK can work with other countries. We have lots, cancer is a globalized community. We have a lot of friends in other countries. And for a relatively small amount of money, you could do an awful lot to improve the evidence base in terms of implementation, health economics, etc., to help countries progress their national planning. And it also builds a more integrated global community. Right now, if you see the amount of research that goes on between high-income countries versus within middle-income, probably less so low incomes, but within middle-income countries, it's not very impressive at all, which again shows gross inequalities in the sorts of clinical research we're doing, clinical trials, producing results which matter in the context of many middle-income countries, and all of that needs funding. High-income countries have it, and we're just not doing it at the moment.
So if you had to pick one priority for the UK's cancer agenda for the next decade, what will it be?
Yeah, I'm afraid I'd go for health systems research and policy, and that includes all the health economics, political economy. I think the technologies don't worry me. People will develop technologies. This is more a question of how on earth do you develop and understand their services and systems? And within that are the issues around the quality agenda. This is about, the big health economic issues in terms of, addressing this. Those are the areas I think from a domestic perspective and also from an international perspective would make a big, big difference. And it's also a very inclusive research domain. I mean, high-end genomics on drug development is a very excluding research domain. Very few people can do this. Whereas, HSRP, political economy, health economics, you can bring loads and loads of people in to do this. You can train people up in these research methodologies. And again, everything, demography, clinical epidemiology, qualitative social science methods, all of these research methods fit into that general domain. And I think that would actually improve things dramatically.
We are looking forward to the UN high-level meeting on NCDs. What single message about cancer do you think they actually need to hear? I'm talking about the world leaders that will be attending the high-level meeting.
It is a significant development challenge, and it's going to require domestic resource mobilisation and rational planning, and it's going to require engagement with the multilateral development banks and other countries like China, the big funders like China, in order to support a very, very focused development on improving capacity and capability. And I think the days of just doing ad hoc pieces here and there are gone. There really needs to be that sort of focus. This all comes down to political commitment at the end of the day. And it comes down to political commitment, and I do understand there is enormous pressures on everything. Every country's governments are being told climate change, pandemic fund, loss of fund from the global fund money, Gavi shrinking. This is incredibly competitive environment. They're going to be putting money into lots of areas. So when it comes to cancer, it has to be really, really super rational, and it really has to deliver the returns on investment that's going to go in. You can't do Mickey Mouse planning anymore.
What would success in global cancer control look like to you?
I'd just like to see more realistic dialogue occurring, led by individual countries, about how they are going to address their cancer challenge. So this is a relook at their national cancer control plans to make them more rational and focused, utilisation of the tools like adaptive HTA to develop a prioritised list of health benefit packages, and a commitment to then financing those health benefit packages for cancer. And I think, side by side, I think you're going to be looking, with some countries, is there needs to have developed then a relationship not just with their own domestic resource mobilisation, but also with where they're going to obtain the money from in a sustainable manner. And I think those discussions are going to be critical. I'm very hopeful, actually. Sometimes I sound very negative, but I'm actually very hopeful. I've been very impressed with International Atomic Energy Agency's bankable document work. I think the PAC missions put together with the bankable documents provide a much more sort of realistic, focused framework for countries to say, okay, this is affordable, this is not affordable, this is what matters, this is not, which doesn't matter. So I think these are all positive steps in the right direction. But it needs to be backed up with more than fine words at lots and lots of meetings, which is what we've tended to have. We have lots of people go to meetings, say, oh, we're going to do this, we're going to do that. We don't really see progress. And then I would argue, this sounds a strange thing to say, but we need better intelligence on what's going on. It's glacial to non-existent progress in cancer epidemiology, registries. We have no idea what's going on in national health accounts with cancer expenditure. The second, NCD dialogue from WHO pointed that out, that we just don't know. So with all of these things, it's great, but how do you monitor and evaluate what you're actually doing? So I think side by side with all of this, you're going to need a much harder view on actually building proper intelligence from countries.
Yes, my very, very last question. on a very personal note, after spending decades in this field, what continues to drive your commitment to cancer research and policy?
I think it's actually genuinely an important area. I think it's an important area when I see, you see avoidable suffering all over the world, and you know that actually a lot of this avoidable suffering is not because we don't know what to do. It's not because the technologies don't exist, the surgery, etc. It's because there's been a political and policy failure, and for that you need a different mindset. So, and I think what drives me is the idea that as a development challenge, this is one of the hardest ones. I understand why we have made so little progress in a sense, because I understand intrinsically how difficult cancer control is in comparison to lots of other areas than in the general health domain. This is a really tough one. I mean, it hasn't been called the emperor of all maladies for nothing. There's a good reason for this. So, and I think that's what drives me is the idea that we can approach this from a different angle, and that can provide the necessary impetus for mindset changes and also the development of new financing approaches that can really see in general improvements. I guess, from just a very personal perspective, of course, cancer and global health is my thing. I have lots of friends all over the world. It's always been, great honor and privilege to work with them and to sort of see things in lots of places actually improve. And whilst we might not see those improvements at the macroeconomic indicator areas and stuff like that, what we do see is certainly over my course of my life, I've seen lots of improvements. And I've seen incredible dedication to training, to building the next generation, to just getting in basic equipment, improving wards, etc. And it's a real privilege to see that kind of determination and drive in a difficult area.
Thank you very much. This has been a very, very exciting conversation.
No, it's really, really a pleasure.
Thank you very much. Enjoy the rest of your day.